All right. All right. Good morning, good afternoon, everyone. I guess we'll go ahead and get started. We're about a minute or two after the hour. Uh, Again, fairly packed agenda for this week. Thought we would circle back to wastewater surveillance since we haven't covered it in a while. But I did want to take some time to give some brief updates on national genomic surveillance and some of the recent changes to designations. So in terms of general updates, or in terms of an agenda for this afternoon session, we'll cover some general updates. We'll talk a little bit about the reclassification of B1, B.1.427, 429. We will give an update on where Delta is currently sitting and some of the data that's out. But I'm hopeful that we will be able to focus most of the rest of the hour, the balance of the hour, on wastewater surveillance and a few topics related to that. Before we get into it, though, I did want to highlight this post from Joseph that posted on general on the Slack. It's a preprint really describing some of the Saliva Direct team's experience in expanding saliva-based testing and in evaluating saliva as a test sample type. I think this question frequently comes up from many different groups. I think this is a really great reference to point to. I don't know, Joseph, or if anyone else from the Yale team is on, any additional comments you want to make on this? All right, well, check it out. I would encourage you. It's a great read. All right, so by the numbers, as of this morning, we're at about 587,000 sequences in GISAID from US labs. It continues to increase, although, again, there are signs of leveling off as case rates continue to decline. GenBank and SRI submissions are at around 346,000, 347,000. So that continues to increase apace as well. For those of so last week I did spend some time highlighting Max's new tool. He's got a script out for those of you that do submit to multiple repositories. I'd encourage you to check it out if you haven't. I'd also I think Max would be welcome feedback and any input on the script itself, any documentation or any challenges that you might run into in using. As you can see from overall submission, so these are, I show this every week. This is breakdown by submission date by submitter type. Over the past 4 weeks, submissions have been down pretty significantly since our peak in May and April. In May, we hit over 150,000 sequences submitted. This month, we're averaging somewhere in the neighborhood of 15,000 sequences deposited per week, just to give you a sense of ballpark. Overall proportions are interesting. So academic and clinical laboratories continue to represent about a third of the submissions to GISAID. Federal sequencing efforts are at about 39% right now, and probably the part that I'm most excited about is that state and local public health departments continue to represent a larger and larger fraction of sequences being submitted. You can see some of this starting to take effect on the curve here, but that's more state and local public health labs starting to come online, starting to apply sequencing for immediate public health response, and that's a fantastic thing. That's what we want to see. Cumulatively, we have 12 states now that have sequenced less than 1% of total reported cases. This is an increase of 1, but we have a few that are sort of dancing on that line between 1% and below. These are completely arbitrary thresholds, but I thought it was a way to measure progress. In some states, we're seeing a little bit of an uptick in the number of cases they're seeing. Similarly, there are some challenges in some states in getting representative samples. So these numbers are likely to bounce around a little bit, but the number of states that have sequenced over 3% has held steady at 16. One thing that I think is a little bit more illustrative, though, is I ran this analysis last night, and it's really just a back of the envelope calculation. Essentially what I did is took from CDC data tracker the total number of reported cases in May versus the total number of collected of sequences submitted to GISAID by collection date. So this should give you essentially a view of how many sequences were submitted in each state as a function of the number of cases that they had for last month. If you look at this, over the May, which I think there's still going to be a little bit of a tail just due to some late submissions, and ideally we want to get that as short as possible. But I figured May was a metric. States, actually, some of these up, especially in New England, haven't necessarily shown, but a number percent of cases at the aggregate that have been sequenced. So a large number are actually reaching public repositories, which is June is a little less indicative, probably. Part of this is the lag time in sequence submissions. I expect this will continue to fill in. That's sort of kept, roughly the last 2 weeks, 3 weeks perhaps might be missing from those sequence submissions. But you can see that a number of states continue to quite a few. Alaska in particular is nailing down a lot of their cases. So a few updates to the official CDC pages and variant tracking yesterday. A few things to note. If you turn nowcasting on, B117 continues to decline over at the national level. We're likely below the 50% range now, somewhere in the 42 to 53% range based on current modeling. Delta, or B.1 at 617.2, continues to increase. This numbers tend to jump around a little bit, especially as new data comes in. It's more difficult to estimate some of those proportions. But current estimates are at 26.1% with a range of 21.5 to 31%. So that continues to increase, and I'll show some figures on that in a second. P1 continues a slow and steady upward climb. It's estimated to be at about almost 15% right now, somewhere in the range of 10.9 to 18.3 is the 95% confidence interval there. One change that in classification is that B.1.427 and B.1.429 were redesignated as variants of interest, down for variants of concern. For those of you that recall, the decision to classify these viruses as a variant of concern was made back in the early spring. A lot of that was driven by the sheer numbers that we were seeing, following that December-January surge. This virus was representing a significant number of cases or sequenced cases in the Western United States. Because it bore L452R, it was impacting the allocation of a number of frontline monoclonals. And since it met the designation criteria, and since we weren't really sure what the trajectory was going to look like, preemptively it was assigned as a VOC. Numbers have continued to decrease. If you look at the nowcast estimates, you can see that in both cases, it's virtually dropped off a cliff. So we decided to reclassify it down to a variant of interest for the time being. But this sort of gives an example of how variant classifications work and how they should work. They should really take into account risk assessment and be continuously reevaluated based on the conditions on the ground. But looking at Delta, I think the nowcast estimates are also important to note that there are some important differences by region. If you look at regions, HHS regions 7 and 8, Delta represents probably a majority of cases at this point. We'll see whether the data continues to hold true. There is quite a bit of variability from HHS region to HHS region. There's a lot of epidemiologic, ecologic, or sampling reasons that could account for those differences. But I think you're also seeing some important regional differences in overall distribution. I would generate these figures, but since the outbreak.info team does such a great job of generating them, I will just use theirs. This gives you a sense of an overall proportions based on GISAID submissions. Again, you know, I have a little bit of caution in interpreting where B1, B.1.617.2 and B.117 are currently. But you know, I think it is clear that they are chipping away at each other, and B.1.617.2 is on the way out. This definitely gives you a sense of trends over time. You can see that 617 or B.1.427 and 429 virtually dropped off. Two of the sublineages of Delta, so AY.1 and AY.2, which I'll highlight in a second, you know, continue to make waves. I drew those out separately here just so that you could see them. The other one to mention is Beta, B.1.351. Numbers continue to remain relatively low throughout the entire United States. So this one has definitely not taken off.
Did we lose Duncan?
It seems like it.
Yeah, looks like it.
He's frozen. Can somebody text him or email him?
We saw him.
He's no longer at the meeting.
Yeah, let's see what he says. He may have completely.
He's back.
All right, there he is.
That was less than ideal. Sorry, guys. Am I back on?
Yep.
Yep.
Excellent. All right. I won't belabor any of this then, because I don't know how much you guys just missed, but it'll all be in the slides. I did want to break it down. So this is based on the last 2 months. You can really see the increase in Delta. Again, here in dark blue, the drop off of B.1.1.7 or alpha over the course of over the past number of sampling weeks. And this gives you a sense of breakdown week to week. If you're interested in looking at the state-by-state breakdowns, again, this is all just based on public data, so it's nothing particularly new, but it's certainly happy to dig into it later if there's interest on any one of these in particular. I did want to highlight Delta in particular, though. You know, we are seeing it in virtually all states at this point. It continues to increase. Numbers continue to increase. There are a few pockets. I did want to call them out of especially AY. We've seen a few cases of AY1 that have been picked up in various surveillance activities. A number of cases of AY2, which has taken hold in a few places, and we have seen at least some evidence of local transmission of these variants, particularly in California. And just a reminder, you know, this is part of the reason that that keeps many of us up at night. You know, if you look at vaccination coverage, there are many parts of the country where vaccination is still well below 50% for eligible vaccine or people that are eligible for vaccines. You also have a significant portion of the country. These are both from CDC COVID data tracker that have significant underlying comorbidities. And if you overlay those two graphs, you know, especially with the emergence of more transmissible variants or rapidly disseminating variants, these can be very concerning. On that happy note, I wanted to turn us over to the main topic for today. Wastewater surveillance is something that we circle back to fairly frequently. There's a fairly significant Venn diagram between those groups that are involved in large-scale genomic surveillance and those that are starting to use environmental and wastewater sampling as a strategy. And you know, obviously, they are extremely synergistic. Today, Mia and the CDC team have kindly agreed to give us an update on news with the National Wastewater Surveillance System. There's a new NCBI data package that's out that we're pretty excited about, and some updates on sampling strategies. And Nuj is going to give us a quick walkthrough of some of the work that they've been doing. So with that, I will hand over to Mia, I guess.
Duncan.
You're-
Okay, just trying to share my screen. Oh, there we go.
Should be good.
Okay. Hopefully this will work. Okay, do you all see that?
Yep, we're good.
Wonderful. I just wanted to start out by saying thank you so much for having us back. And like Duncan said, this is just a really exciting time for wastewater work, but also we're really excited to be connected with your group and the brain power here with respect to just for SARS-CoV-2, but beyond. And we'll talk about that in a little bit. I also wanted to acknowledge our new science lead for our National Wastewater Surveillance System, Rory Welsh. He is him and our bioinformatics lead, Shatavia Morrison, are also two that have been working very hard on the wastewater sequencing aspects and using this to understand the genomics of SARS-CoV-2 present within a community. So please let me know if you can't hear me at any time. My computer likes to cut out audio a lot. Oh, can you all hear me still?
Yep, we're good.
Okay, sorry, your video disappeared. So before we provide an update on our sequencing efforts with respect to wastewater, I wanted to quickly review just wastewater surveillance in general and CDC's National Wastewater Surveillance System that I shared about a few months back for those that maybe weren't able to join or don't think about poop all the time. So quickly, wastewater surveillance is really just the strategic sampling and testing of pathogens or other health targets in wastewater to better understand disease burden and spread within a community. So it essentially serves a similar function to a pooled clinical sample. But wastewater surveillance is not a new idea. Many of you know that for decades, CDC and other researchers have been using it for polio surveillance, for example. However, this type of surveillance has never been implemented at scale in the US, likely due to the infrastructure growth that needed to happen to do that. And it really hasn't been used for a public health response of a respiratory infection. But then COVID-19 happened and we had all the momentum we needed. So since the majority of poop in America will be flushed into the sewers and arrive at a wastewater treatment facility within hours, untreated wastewater is, like I mentioned, an efficient pooled fecal sample representing community level or even sub-community level infection burden if strategically sampled from within the pipe network and not just at the treatment system. So wastewater surveillance is a measurement that is really independent of other existing surveillance systems. And what's powerful about that is that means it's not impacted by healthcare seeking behaviors or access like many of the other systems. So it doesn't matter whether people go to the doctor or clinical testing capacity is limited, wastewater surveillance can still be a robust measure of community infection. We also know that about 50% of individuals with SARS-CoV-2 will shed detectable levels of virus RNA in their feces, and that number may be even higher. And this shedding happens, we think, very early in an infection, and it happens both in symptomatic and asymptomatic infections, and it happens both in children and adult infections. So this means that wastewater surveillance can provide a systematic data that reflects total infection burden, unlike clinical surveillance, which is biased towards symptomatic and severe infections that are captured with testing. And finally, wastewater surveillance is fast. We can have community level data in hand within 5 to 7 days after the toilet is flushed, and that's a very conservative turnaround time compared to up to even 2 weeks for clinical indicators as case counts, such as case counts or hospitalizations, depending on after onset of symptoms, depending on the testing and availability in that area. So there are even being technologies evaluated for on-site and same-day testing of building level wastewater samples for infection presence screening. So it's quite quick. And what CDC evaluation efforts and researchers across the world consistently found when looking at these data early on in the pandemic was that wastewater signals correlate with newly reported cases and hospitalizations. And depending on the case reporting time lags, that correlation of or the wastewater trend correlations can lead that cases or hospitalization data by about around 4 to 6 days. So that can be even longer in some cases if there are great reporting lags. So for that reason, that's the million-mile-an-hour overview of the justification for this. In September of 2020, CDC launched the National Wastewater Surveillance System, or NWS, NWSS, as we like to call it. So this is a schematic of how NWS works. And starting in the top left, sewage from communities is collected by wastewater treatment plant utilities, and that can be at the treatment plant or, as I mentioned, upstream. The utilities collect samples of incoming raw wastewater or even sometimes the concentrated biosolids at the treatment plant, which are then taken to laboratories capable of molecular analyses of these environmental samples. The labs then send those results to the state and tribal, local, and territorial health departments, where it's then uploaded into the NWS data repository and analytic engine and Decipher housed at CDC. So through our Decipher system, which all of the other surveillance systems are also housed, NWS makes analytical results rapidly available to the health departments and allows states to view the data from other states to better coordinate and understand transmission and neighboring communities. And really with respect to both presence of the virus, which we're not really in that phase right now, but mostly also with respect to trends, again, and total infection burden and that correlation with cases and hospitalizations. So with the launch of this system, there's really been a rapid uptake by states nationwide. This is a map showing currently our 36, what we call the epi and laboratory capacity funds funded jurisdictions. So we have already funded a total of $223 million for wastewater surveillance activities across these states. And the stars actually represent local jurisdictions that have received funding, city municipalities. And there's an additional 34 million that will go out within the next month or so, which we think will increase this by another 10 states or so. And as you can see on the graph on the right side, you know, we in early June, we surpassed the 10,000 data point mark in our Decipher in terms of individual wastewater sample results that were submitted into our Decipher system. So quite a quick increase, and that's not all of the states in blue are submitting data yet. Some of them are getting their programs up and going. So it's really impressive how much data can be generated quite quickly. So I also wanted to go over just how these data are already being used in the response, because sometimes for those that don't work with these types of samples a lot, that can be really difficult to think through, okay, what do you do with this? So state and local jurisdictions, as you saw from the map across the country, are already using these data to inform their response decisions. And they're doing, a few examples of this include the independent confirmation of a true increase or decrease in cases. Sometimes you see that trends and different types of surveillance are conflicting. And so it can be an independent tiebreaker that says, no, this case increase isn't just because of increased testing availability. We think that this is a true increase in overall cases. Some are using it to inform their distribution of and siting of testing, as well as now vaccination sites. They're also using this to help provide surveillance data in communities where clinical testing really is limited or not available at all. They're using it for near-term forecasting of cases or hospital utilization in terms of preparation of resources. And finally, they're using it for monitoring the impact of home testing. So there's actually two different sides of this. We've seen states that have used it for designing their sampling strategy when it came to point prevalence studies, door-to-door point prevalence studies, and then also using the wastewater data to evaluate the impact of providing home testing in the mail to individuals and whether that corresponds with a decrease in community levels of infection or not with that access. So while those are a lot of really exciting examples, because wastewater is used to understand community infection trends, even more exciting, it could be the use of wastewater for informing variant circulation. However, this is much more in the development phase. So we may have heard about this a little bit. It's been in the news some, but we would like to call it, instead of variant tracking, SARS-CoV-2 mutation tracking and wastewater. And I'll explain that in a little bit. So we really think kind of the broad thesis statement is that wastewater really looks like it will be useful for mutation detection and possibly variant trend tracking within a community, but still unclear about the utility of it for discovery of new mutations, and especially the discovery of new clinically relevant variants. And that's because there's several public health interpretation challenges when it comes to wastewater. The fact that SARS-CoV-2 genomes make up only a small fraction of the genomic material in wastewater make it really difficult to sequence. And any nucleic acid enrichment process, as we all know, to improve that detection could introduce biases in the mutation abundances or even presence. Moreover, sorry, get my scrolling. Many of the SARS-CoV-2 genomes present in wastewater are likely fragmented and consist of many different mutations associated with a variety of variants that could be circulating in a community. So it's not it's a very diverse sample. Also, it's not clicking. Oh, there. Well, now it all clicks. Also, if you are targeting a specific mutation to track, you have to know what that mutation is, and you have to make sure that that mutation that you're targeting is very specific to the variant of interest, because it's really difficult to assess specificity of mutation associated with a variant at this point, especially because it's so dependent on clinical sequencing databases that can be biased towards one variant or another, and that any additional mutations in a prime or pro binding region can impact these assays and underreport them. And also, we just don't know how often these mutations may be present, particularly in those asymptomatic cases that may not be associated with a variant that we never get a clinical sample for sequencing of. Finally, shedding rates of SARS-CoV-2 and associated variants are still not well understood. And this shedding may be impacted by changes in illness duration and severity from variants of concern, particularly, as well as immune response from vaccination. So it can go both ways. And altogether, it's making the relative abundance of a variant's infection burden in a community from wastewater data not possible at this point. Excuse me. And then finally, the timeliness of this is really not known yet. It's related to the lack of information on fecal shedding. So it's unclear that if there is a variant that has different GI clinical aspects, it could be that the timeliness of wastewater for those variants is not the same as it has been for the wild type. And so it's still unknown. Okay, so since we're going to talk about wastewater mutation tracking, we wanted to first go over that there are, first define what we mean by that, and then go over the two most common methods for doing this. So wastewater mutation tracking is really just using it to evaluate the potential presence of variants that are known to carry those mutations, shedding by infections represented in that community. So having the 501Y variant present and mutation present in a wastewater sample could suggest that the UK variant was within a community. So for that kind of screening approach. And currently, Tracking wastewater is currently done using these two different approaches, either by targeting a known mutation, as I mentioned, through the specific RT-qPCR or digital droplet assays, or by sequencing, which we're going to talk about today. And sequencing methods involve either a specific genome region, tiled amplicon sequencing across the genome, or true metagenomic sequencing of all nucleic acid within a sample. And importantly, these approaches provide information on the presence of mutations in the SARS-CoV-2 genome circulating community, but don't confirm the presence of SARS-CoV-2 variants, because obviously the variants are typically defined by multiple mutations across the genome. In contrast to individual patient samples where mutations detected in different genome fragments can typically be assumed to belong to that same SARS-CoV-2 genome, the massively pooled nature of wastewater samples make linking mutations to different genomic regions and linking those regions together very, very difficult. This means that targeting mutations provides data on the presence of a mutation in a community, but cannot tell you whether a mutation is directly associated with a particular variant or provide information on that relative clinical burden, as I mentioned. However, by quantitatively monitoring multiple known mutations associated with variants, this approach could potentially provide information on trends in variant infections within a community. And researchers are actively working to validate that approach. It's something that's used in environmental ecology and tracking community changes of microbes. So hoping that has a similar result here. Along those same lines, sequencing can provide information on the relative abundance and diversity of mutations, including potentially identifying novel mutations in a community, though it's difficult to know if those novel mutations are from a clinical patient or not, as when you have small fragments and there are other coronaviruses present in wastewater. And that's why that's still a little bit unclear. But like targeted PCR approach, sequencing cannot tell you the total abundance of mutations, the proportion of variant infections inferred by the proportion of mutations detected over the total virus measurement, or identify a consensus SARS-CoV-2 genome, especially a novel consensus genome. So we provide an asterisk there because the science behind all of these approaches are really rapidly developing. And I never want to limit or say definitively what something can or cannot do. And consensus genomes from wastewater could potentially be possible with deep and long read sequencing when there's really low viral diversity, say when the UK variant spread across the UK and it was pretty much majority that variant of infections that were circulating in the community. So while all of these approaches have limitations, the data are still informative now. And like total SARS-CoV-2 trend data, wastewater mutation tracking data are meant to really complement the clinical variant data that we see. So what is the state of it? So just to give that overview, despite the challenges, we feel like that wastewater is still an incredible resource of data for understanding that genomic diversity of SARS-CoV-2 infections in a community, and particularly since wastewater captures both reported and unreported infections. But the performance, namely the sensitivity and the timeliness of tracking mutations, is still being evaluated with paired clinical data. And as you can imagine, that's really difficult to do, especially in real time. We also wanted to point out that both the wet lab, so while we have a process for quantifying short read targets using qPCR or digital droplet PCR of the genome, the wet lab aspects for getting quality nucleic acid for sequencing, as well as the bioinformatic analytical methods for identifying mutations and potentially linking them to variants in a mixed complex wastewater sample are either not available or still under intense development. So therefore, we want to really stress that clinical sequence data are still needed to confirm variant presence indicated by wastewater data, as well as associated clinical burden and clinical significance. But at this moment, we feel like it's useful now for screening communities for mutations of known variants, possibly evaluating the trends of those known variants, as I mentioned, and finally identifying and emerging and potentially disappearing mutations in a community by evaluating over time. So I just wanted to share a couple of examples of inquiries that we're getting from public health in the field right now using these data and what they're struggling with these types of data. So the first is, what is the best way to communicate targeted mutation data supporting a variant of concern present in a community? And we feel that this data can be shared with the public despite the limitations and could be impactful for encouraging mitigation behaviors like mask wearing and vaccination. But we all have to be very careful with our message that doesn't overstate what these data can confirm, and remind the public that wastewater data is meant to support the clinical variant data that's available and provide information when other information isn't there. Just like all surveillance data, it is not perfect. The second question we often get is, and I think I've mentioned this a couple of times now, can the proportion of variant cases be determined from a quantitative targeted mutation data? And at this time, the answer is no. As I've already mentioned, this is due to the lack of fecal shedding data and the fact that using the targeted method, you cannot confirm a mutation is present within the genome of a specific variant. So that clinical proportion cannot be inferred. And finally, can you infer vaccine efficacy or pharmaceutical resistance, which came up when talking about Duncan talking about some of the previous variants, from the presence of mutations associated with unknown variants? So if this is a mutation that we have not seen clinically before, but if it means that it's in a human being, then it could have really important implications with respect to, say, vaccine breakthrough or pharmaceutical resistance. And again, here the short answer is no, but wastewater detection of mutations that could theoretically result in these important outcomes can serve as a really critical alert to public health to these potential variants or mutations that could be variants for investigating with clinical sequencing. So really that complementing of clinical sequencing. So we felt like at CDC, one of the most important roles that we could play here is helping to coordinate all of this data because of the promise of sequencing for both vaccine development as well as understanding variant circulation. There are many researchers, industries, public health partners actively generating these data already. However, it's a new tool. And as I mentioned, the analytics and use of the data are still under development. So we felt like one of the most important aspects of this work is coordinating the submission of wastewater data for disease surveillance purposes. And at this time, obviously, namely for SARS-CoV-2. And for this reason, CDC partnered with NCBI to tackle this process of creating a coordinated metadata submission for wastewater sequence data. And this was a challenge and not something that was available with the current resources because for the following reasons, there could be multiple sequencing methods for a specific target in wastewater. Maybe you do long read as well as tiled amplicon sequencing for SARS-CoV-2 in order to get a more robust result. So multiple SRAs per single target. There can also be multiple targets per sample. Wastewater is rich in disease information. So there's a lot of other targets that could be looked for as well. And there's a lot of other information that is used to help understand the SARS-CoV-2 that is measured in wastewater. We also wanted to build something that would allow this sequence coordination to be applicable beyond SARS-CoV-2 and internationally useful, because while obviously NCBI is a US institution, it serves as a database internationally, globally, and we want to be able to have any submissions be useful to everyone. And so that gets at what metadata must we require for that utility. And finally, we wanted to make sure any new nomenclature that we're using is consistent. We did partner also with Ruth Timmy from the phage work group on this as well to consult on this development for our biosample package because we wanted to make sure that we were striving to be standardized and consistent. So on the right-hand side, you can see the mandatory metadata that we required in order to address each of these challenges. A couple of the big ones obviously are date and location, but only down to the state level, the target organism, and the population served. So we want to know if this sequencing information represents 10 people or 10,000 people. And that's really helpful for those comparing their results and their genetic information in other areas. And so you can explore some of these other mandatory metadata by viewing the package. So this is the biosample package that was produced, and the link was shared in the chat last week through the SPHERES Slack channel, but it's also available on the same site as the SARS-CoV-2 clinical biosample package. And it's really exciting to have this set up not only for coordinating sequence data from wastewater surveillance in the US, but also connecting these efforts globally. It has a field for a wastewater surveillance program specific ID for the US. This would be a news ID in order to link these data to abundance of metadata gathered through CDC's surveillance system, news surveillance system. And while this was done to support COVID-19, again, this was designed to be supportive long after for any health target. And we are currently working on a detailed guidance for the submission with specific examples and a crosswalk with the news variables to minimize, redundant public health data submission, but more to come on that soon. And it should be released through protocols.io. And I will, again, link that in the Slack channel. So just want to end by quickly saying the next steps. This is an example of the type of clinical burden that we'd love to be able to generate from wastewater data, but we're not there yet. So we've created this interagency collaboration to work on the pipeline for analyzing SARS-CoV-2 sequence data from wastewater. We also are doing in silico bioinformatics evaluation and working to gather lots of sequencing data through an HHS public-private partnership for nationwide testing of wastewater, all of our new state partners and researchers that are being funded through the BAA mechanism at CDC, and other researchers that are just wonderful in submitting their data to NCBI and have been waiting for this biosample package. And finally, the goal is once this pipeline, we feel like we do have an analytic approach that supports public health, that to have it internally connected, those results through NCBI's internal pipeline through our HHS Protect Cloud to our News Decipher dashboard. And that will rapidly appear to provide those data back to public health as soon as possible. So if you are excited by this possibility and you've got ideas, join us. This is really something that's supposed to be interoperable, really adaptable, and has a lot of other applications shown here than just SARS-CoV-2, but obviously that's what we're focusing on now. So thank you so much. And please feel free to email us at news@cdc.gov.
Thanks, Mia. That was fantastic. Any questions? We have probably a minute or two. I want to give Anu some time since he's going to take us through some considerations around sampling strategies for rural settings or rural watersheds. But that was a lot of information all at once. I'd encourage you to check out the new data specification. And as Mia said, this potentially has far-reaching implications beyond the SARS-CoV-2 response. So very exciting. Eager to hear more. Any thoughts from the group or any comments?
I have a question, kind of in general about wastewater testing. Do you all see any utility in performing wastewater testing, say like for a prison or some large commercial building, in terms of a way to kind of establish if that particular population may have positive people present? What are your thoughts around the utility of that?
Yeah, so one thing I didn't mention, I would encourage everyone to go to our website. If you just Google CDC and NWSS, we have a whole page on targeted wastewater surveillance screening, and there's a lot of nuances to that. But yes, we see a lot of promise for that. We have actually we are coordinating and funding a project across several different state correctional facilities at several different states to look at the best way to do this. But we kind of say that this is the screening application of wastewater surveillance. So correctional facilities, long-term care, nursing homes, these are all being really looked at hard for SARS-CoV-2 and again, future targets that we know were always really difficult to monitor in these settings. So we definitely do. And I encourage you to reach out to or look at our website for a little more nuance and consideration for those approaches.
Okay, thank you.
Mia, just a quick question on for sewage surveillance, what's the average concentration of genomes per microliter that you get? Is it extremely dilute, or is high concentration an issue?
So that all depends on how many cases you have. So that's the whole point, is that we're tracking the trends in this. And, you know, it's anywhere from, I think, you know, 1,000 copies per liter to up to, you know, 1 million, and even some have reported 10 million copies per liter. And there's a lot of detail on this that I can go into in terms of comparability, difficulties in comparability of methods and everyone using different methods right now. But we are getting to a point where detection limit is an issue, which is great in terms of case numbers. And that's where biosolid testing is really proven very useful because of the concentration impact of sludge. A lot of different concentrations.
The main reason why I ask is because Paul Deere in Sanger pioneered a method called happy mapping, and it's primarily for mapping out genotypes based on diluting out molecules. So I can reach out to you offline and see that might be a way to do some variant tracking since you're starting with dilute samples already.
Yeah, that would be great. We are open to any and all ideas. Yeah.
Okay.
Thank you. Yes, and I'm glad. Please look in the chat, because there's a lot of people that are doing this that have shared some of their resources. Noah from Wyoming and Mark Johnson from Missouri, and others that are really in the weeds on this as well.
Just to remind everyone, there's both an environmental sampling channel, and I think there's a wastewater channel as well on Slack.
Yes.
So
Yep. Please join, and feel free to put any of those resources actually that you share. If you put it there, it'd be nice, because then all of the other groups will have that available as well.
Hi, this is Dave O'Connor from Wisconsin. I'm wondering, looking at NCBI's biosample right now, when I search for wastewater, I don't find a result, but there is one that says MIGS, M-I-G-S, virus wastewater. Is that the biosample package, or is there a different one that we should be using?
That is not the biosample package. So let me put the link in the chat. It should be, yeah, I'll put the link in the chat.
Great, thanks.
Yep.
We probably just have to fix our search so that it picks up the new package. I'll put in a ticket for that. Thank you.
thanks, Eileen. Instant fixes. We love that here. All right. Thank you, Mia. That was a wonderful overview. And again, you know, I think we're extremely excited by this. I wanted to hand over now to Anuj to give a quick overview. You should have the ability to present.
Yeah, thank you, Duncan. Let me share my screen. Is it good? You can see my screen, my poster?
Yep, you're up.
Thank you. So a very good afternoon to everyone. Hi, this is Anuj Tiwari. I'm a postdoctoral research associate at Discovery Partners Institute, Chicago. Today, I'm here to discuss one of my recent research work on optimizing COVID-19 wastewater sampling strategies for large rural regions of Illinois state. But before I discuss this in detail, let me give you a quick brief about my project. So from the last 8 months, I am working with Discovery Partner Institute science team headed by Professor Rachel Prosky and Charlie Catlett on the Chicago wastewater-based epidemiology project with a great and diversified team of researchers, as you can see into the author list of this poster, and of course in our collaborations from the domain of public health, life sciences, data sciences, and engineering. Now we are leading both Chicago and Illinois COVID-19 wastewater efforts. In Chicago wastewater project, we are sampling all 7 wastewater treatment plants of Cook County. Like many other researchers, our experience with this project help us to understand that wastewater-based epidemiology is an effective tool in the fight against the COVID-19. And yes, it provides rapid and non-invasive insights regarding the health of large or targeted populations inside the wastewater treatment plant catchment area. But many public health questions require insight across many communities, such as at the county or at the state level. And if I talk about the figures and the state of Illinois is primarily a rural region comprising 58,000 square miles with a population of roughly 16 million. Similar to the other state, over half of the Illinois population live within 50 miles of its largest population center. And in case of Illinois, it is Chicago City. Outside of the Chicago area, Illinois has roughly 140 cities with the population greater than 10,000 and nearly 1,000 cities with the population under 10,000. So in order to understand and track infectious disease like COVID-19 across these communities, a comprehensive wastewater sampling plan would involve over, I should say, nearly 1,000 wastewater treatment plants and countless private septic systems. So when we were extending our project from the Chicago city to the state of Illinois, we started thinking about developing an optimal wastewater sampling strategy, a sampling strategy that will not only index the communities as per the impact of the COVID-19 pandemic, but also prioritize social, economical, racial, and rural diversities while making any decisions regarding the wastewater surveillance. So let me zoom it for you. So if you look at the first part of the poster, last year in September 2020, we introduced the random forest machine learning based COVID-19 vulnerability index using 6 different themes: socioeconomic status, household composition and disability, minority status and language, housing type and transportation, API factors, healthcare system factors. In order to train our machine learning model, we also developed an innovative COVID-19 impact assessment algorithm using homogeneity modeling and temporal trend assessment technique. Developed index was also compared with the CDC CCVI using statistical measures and the machine learning model. In the next step, if you will see, we further refined this COVID-19 vulnerability index in early 2021 with the additional demographic, sequencing, and more innovative Walmart shared information. As you can see in the different maps, we use CDC social vulnerability index, COVID community vulnerability index, COVID-19 vulnerability index, to understand the vulnerability from the different perspective. We further computed the trend and the homogeneity at the zip code level cases data set to understand the impact of the pandemic and resilience of the community at the zip code level. Considering the role of the supermarkets in spreading COVID-19, we used Walmart locations and overlaid them on the trend map to delineate the Walmart share. Walmart share is an interesting term coined back by Charlie, my postdoc mentor. It is a catchment area of the zip code around the Walmart showing the similar trend. We also used Illinois city population data set and the COVID-19 Restore Illinois regions to develop 2 obvious sampling strategies: the largest population center within each COVID-19 Restore Illinois region and the largest population center in each of the Illinois 102 counties. So as shown in the results, when top 1/3 vulnerable counties overlaid on the sequencing details, we can identify those rural Illinois counties which are suffering from the COVID-19 but don't have any genomic sequencing going on. We further use zip code level, trend map, and the population data set to select the cities inside these counties for wastewater sampling. Comparative evaluation of our sampling approach with the largest population center in COVID-19 Restore Illinois region and in each of the Illinois 102 counties describes that. These 2 approaches majorly focuses on large population centers around Chicagoland and left vast rural area unexamined, while our approach successfully focused on prioritizing the rural communities for wastewater sampling. This study also helped us to learn many different lessons around wastewater sampling, and the most important lesson is, if we look at the large areas like Chicago City, the sewer set rarely align with the municipal boundaries because they are shared. And the population served by sewer set is so large, like we have the world's biggest wastewater treatment plant, Stickney, which serves 2.3 million population. that in order to isolate the hotspots and the resurgence inside the wastewater treatment plant catchment area, it is necessary to develop a sampling strategy that isolate and sample sub-sewer set inside the wastewater treatment plant. While in case of lower population density areas, like majority of Illinois state and the other states, although the sewer set are well defined and they well aligned with the municipal boundaries, but the sheer number of the sewer systems require a sampling strategy that balance population coverage with the geographical coverage. We are also in the process of validating our sampling scheme with multiple experiments that is planned in the next 2 months. Thank you. That's all from my side on wastewater sampling. Soon I will come up with the more results on the wastewater sampling and the data analytics for the city of Chicago and the Illinois state. I appreciate your time and consideration. Thanks.
Thank you so much, Anu. As a dyed-in-the-wool molecular lab scientist, I always completely get lost once we start talking about large scale and some of the large scale engineering applications of wastewater surveillance and some of the considerations that need to go in. But I think especially in looking at some of those rural areas that are covered by a vast geography, a lot of different selection criteria. I think trying to think about that and wrap your head around the problem, that's a great introduction.
Yeah, thanks.
Any thoughts from the group?
So I think I have some suggestions in the notes in the chat box, and rather the questions, I have some suggestions and the contact requests. So I will do them offline. Yeah.
Sounds good. Well, I'm sure that the conversation will continue offline. Again, I'll remind everyone that the wastewater and environmental sampling channels do exist on Slack. And actually, I see that we actually are back on a trial version of Slack. So the backlog of messages should actually be solved, at least for the time being. I'm still working on getting support in place for Slack. It's proving to be somewhat challenging with our IT organization, but hopefully that will be resolved longer term. But looks like at least for the next 6 months we're solved. Anyway, that's it for today. Any final words to send us off? All right, in that case, we will talk to you all next week. Thanks all.
Bye, thanks.